Good morning, all participants. Welcome to the talk presented by the Division of Nephrology of Wits University and the Charlotte Macheke Johannesburg Academic Hospital. It gives me great pleasure to introduce Dr. Nina Diana, who is an extremely experienced senior consultant nephrologist at Johannesburg Hospital. She has been with us for many years. And one of her important interests lies in the field of living donor renal transplant. She is certainly very qualified to talk to us about this subject today. And on behalf of the division of the most important organ of the body, I hand over to you, Dr. Diana. Thank you.
Thanks, Professor Paget. You make me sound so old. So you can hear me?
Yeah, we can hear you.
Okay, so I'm going to be talking about barriers to transplantation and about potential solutions that we can enact. Oh, I'm struggling to just move my own slides along. Hold on one second. Okay, so I hopefully don't have to convince anyone that kidney transplantation is good. Compared to maintenance dialysis, it provides an improved quality of life, a mortality benefit, and also at a lower cost to the healthcare system. And our aim really should be to minimize patients' time on dialysis and get everybody transplanted. So the International Society of Nephrology published this article in 2020, and it outlined the importance of transplant as a treatment option for patients with end-stage kidney disease. They outlined the basic requirements for an effective transplant program, and it's nicely illustrated in the picture in the diagram on the right-hand side, the pyramid. And for an effective program, you need buy-in at multiple levels. You need commitment from government at a national, regional, provincial level. You need commitment from your hospital, from your healthcare workers, from communities, from patients and their families. So it's a complicated process. So why is there such a large gap between the number of patients who are waiting for a kidney on the list and the number of patients who actually receive a transplant? And you can see here, we've got, this is US data, they've got 90,000 people on the waiting list. And in 2021, they did 24,000 transplants. And this is related to this continued increase in ESRD burden with a relatively slow increase in the number of transplants being done. And in the US, 20 patients die every day on the waiting list waiting for a kidney transplant. So what's happening in South Africa? It's been estimated that by 2030, more than 70% of patients with end-stage kidney disease in the world will reside in low and middle income countries, just like ours. And this obviously is an issue because we have limited funds for kidney disease care because of our significant burden of communicable diseases. This is renal registry data from 2019. And it tells us that there are almost 10,000 patients on dialysis in South Africa, and 900 of them started dialysis in 2019. So we're adding a lot of patients each year to this list. And there are 291 dialysis centers in South Africa, which have 34 in the state sector, so the majority in the private sector. And we have a number of transplant centers. We have 14 accredited centers across the country. So if we look at transplant rates, in America and Europe, transplant rates vary from 35.5 to 40.5 per million population. Africa as a whole has very few transplant centers, and our transplant rate in South Africa is all the way down at 6.4 per million population. It's much lower than it actually needs to be. So the question is, why are we so far behind, right? Partly because we have such a huge growing burden of end-stage kidney disease. We have a diseased population. We have the highest rates of hypertension and obesity in sub-Saharan Africa. We have the highest burden of HIV in the world. Some of our population have high risk APOL1 risk genotypes. Our primary healthcare is not great, and many patients present late. The next issue is that we don't have enough trained personnel. We don't have enough nephrologists. We don't have enough transplant surgeons. We don't have enough transplant coordinators. Another issue is that we don't have enough donors, deceased or living donors. So this shows you our kidney transplantation in South Africa. It's quite embarrassing. In 2009, we did 224 kidney transplants across South Africa. So if you remember, we have about 10,000 people on dialysis, and if half of them are transplantable, that leaves us 5,000. And if we're going to be generous and do 250 transplants a year, it's going to take us 20 years to clear the people who are currently on the list without adding anyone else to the list. So our first barrier is a lack of transplant education. There's a serious lack of knowledge around transplantation. And this is specifically around organ donation, about the concepts and diagnosis of brain death, about how to refer a patient to the transplant team, and also about how do we communicate with patients and families around topics around donation and about consent for donation. So this study was performed at a tertiary hospital in Limpopo, and they surveyed 300 people who came to the general outpatients department, so not to the renal department. They just came to the hospital for some other care or accompanying a loved one. And their survey covered questions involving kidney donation and attitudes to transplantation. And only 13.3% of participants were willing to donate a kidney. And their main concerns were that the transplant process may change their bodies, or that there may be potential complications after the transplant. So being scared to donate and cultural beliefs were given as the biggest barriers to transplant. 73% of the participants felt that they must die with their bodies intact. It's been well documented that organ donation rates are affected by the healthcare personnel's attitude to organ donation and transplantation. And here, Okpera et al. Looked at knowledge and attitudes of healthcare workers towards kidney transplant. This was done in Nigeria. It was a self-administered survey, and it was done at a pediatric conference, so with nice humans. And they were all doctors or nurses who participated in this. And on average, the healthcare workers responded correctly to about 64% of the questions. Only 50.7% were willing to donate a kidney. So 56.5% of the doctors and 33.9% of the nurses. However, 76% would want to receive a kidney. So if we can't convince ourselves that we need to donate organs, how are we going to convince the general population that this is the right thing to do? So this is some data from South Africa. On the left, you can see there's an article about attitudes of nurses to transplant in Joburg. And the majority of nurses had a positive attitude to transplant. 80.3% said they themselves would refer the patient to a transplant team if there was a referral process and protocol in place. 61%, however, were unaware that there was actually access to a transplant coordinator through their hospital. And most of the hospitals where this is done, organ donation actually occurs in the building. On the right, looking at medical students and how they do with diagnosing brain death and concepts around brain death. This was conducted at UCT, and the authors concluded that medical students can't make a diagnosis of brain death, and that transplant education really needs to be integrated into the curriculum. So what are some potential solutions to this lack of transplant education? So in the general population, in the UK and in Japan, they've started introducing concepts around organ donation into the school curriculum. And they found that not only does it help to introduce the concepts when the kids are at school, but they also go home and talk to their parents about it. And it gets the conversation started in the family household about organ donation and concepts around organ donation. And you chat about it, and you know what your family want with regards to their own organs. Next up is we can do promotional activities or campaigns, not only towards health promotion, so you never get to end-stage kidney disease, but also about organ donation and organ donation drives. Studies have also shown, there's a nice study from Israel that's shown that religious and community leaders, if they are in support of organ donation, that rates of donation actually go up. If they come out in support and say that it's not a violation to the body to donate organs, that rates of transplantation have gone up. As healthcare workers, we can do a lot here, right? We can advocate for transplant. We can speak to our patients, to our colleagues about the benefits of transplant. We can educate people about how to refer patients, who they need to contact, If they're unsure about whether the patient would qualify, it's better that they refer the patient. We can also have a look at how we communicate with our patients and their families, and think about how we communicate would potentially influence their decision that they make. Ongoing research and transparent dissemination of the results is also important. So the SAMJ and the South African Journal of Critical Care released these guidelines on determination of death last year in 2021. And the guidelines, it's comprehensive, and it covers how to determine brain death and also how to determine circulatory death and what the requirements are by South African law. I suggest you all have a look at these. And at the end of the article, they have this, sorry, where is this? Okay, I can't get rid of it. At the end of the article, they have this useful check sheet, right? And this is to diagnose brain death. And in South Africa, 2 doctors are required to diagnose brain death. One must have more than 5 years experience. And the tests are listed here, what has to happen to be able to diagnose brain death. And doctors from the transplant team obviously can't be involved in this process. There are also 2 more summary sheets that tell you about how to do the clinical tests for brain death, and also how to do the apnea testing. Both of these are very useful, and I really suggest that you have a look at this article. The NEJM also happened to publish an article in December of 2021 about determination of brain death, and they've put it into a nice algorithm here. But what is great about this particular article is there's a video section on how to do all the testing for brain death, and it's quite nice. It runs through and it shows you exactly how to do it. So I also suggest you have a look at this. Our next barrier to transplant is we don't have enough deceased donors. Okay, and this is related to a number of factors. Again, healthcare teams don't declare brain death. They don't refer patients. Another recurring issue is that we don't know how to speak to our patients about these sensitive topics. You know, sometimes they've shown in studies that doctors, you know, we feel like a failure when we fail to save the patient, and now we're almost embarrassed to have to ask the patient's family about whether they'd consider donating organs. Family refusal, we're going to have a look at that and why families refuse. Funding, obviously, is a big issue. And then, are we being held back by our opt-in donation policy? So why do families refuse, right? Okay, there are a number of reasons. Families are refused because they are unaware of what your wishes are, right? They've never had the conversation with you. You've never had the conversation in your family about, do you want to be an organ donor? Are you okay with it? Are you not okay with it? They themselves might not have knowledge around donation. They might not understand the concept of brain death. Now, you're telling them that their family member's dead, but they can see on the monitors that their heart rate is still going and they still have a blood pressure, and you know the ventilator's still, you know, they're still breathing to them. So how could they possibly be dead? They also might be worried about, are there any additional costs to this? Or it might delay the funeral, which may be really important to one's religion. They might also have issues around medical mistrust. They might worry that during the organ harvest, the patient's body is going to be mutilated. These are all things that we could address. Now, lack of funding is also another big role, particularly in our constrained environment. You know, donors need ongoing care. This usually requires ICU care, and it blocks a bed for a different patient. You know, we're always pushed for beds in the ICU. Also, trained personnel are needed to look after these patients. They often are, you know, they're ventilated, they're often on inotropes. So they need trained personnel to be able to look after these patients. It's, you know, it's not appropriate for them to be looked after, you know, in the corner of the ward. But because of constraints, there may be pressure to turf these potential donors to the general ward. Okay, so what are some potential solutions to this? Okay, again, religious and community leader support, really important to get your community involved. What about if we had protocols in place for donor referral, or about how to declare brain death? You know, we could print that handy sheet and have it available everywhere. We need available ICU beds. We need dedicated surgical time. Then we're going to have a look about some other options. What about donation after circulatory death? What about donating across histocompatibility barriers? What about xenotransplantation? It's made the news recently. And what if we changed our opt-in to an opt-out policy? Okay, so this is this is data from the UK, and Hulme et al. They reviewed all patients in the UK that were referred to the transplant coordinator over a period of time. and it included about 4,900 people. And consent for a positive outcome, so consent for donation, was most strongly associated to two factors. The first was the knowledge of the patient's wishes. Had the patient and their family had a conversation about this? And was there an organ donor card? Okay. The next most strongly associated was there involvement of a transplant coordinator? And if you remember back to our data in South Africa, in 2015, we only had 22 transplant coordinators in the entire country. But in the UK, they have a lot of these nurses that are trained in organ donation, and their presence during this process was strongly associated with families consenting to donation. Okay, so instead of only using organs after brain death, many countries utilize organs after circulatory death. And in the graph on the left, the red bars show the organs that are donated after circulatory death, and you can see it adds quite a bit to organ donation. So Spain, USA, Portugal, France, UK, Italy, Australia, Switzerland, a little bit in Sweden. And on the right, you can see that organs after donation after circulatory death in the UK has led to a great increase in the number of organs available for transplantation. So some people, you might be concerned about what is the outcome like with these donations. And this is UK registry analysis, and it compares outcomes at 10 years between donation after circulatory death and donation after brain death. And you can see that donation after circulatory death, there was an additional 3,626 organs that were donated. So it has increased the numbers by more than a third. And whilst they did have longer delayed graft function, so they took a bit longer to start working, renal function at 5 years and graft survival at 10 years was similar in both groups. Okay, so there's a lot of noise about opt-in versus opt-out policies. So South Africa has an opt-in donation policy. This means that when you die, your family has to opt in to donate your organs. Some other countries like Spain has an opt-out policy. So when you die, they automatically assume that you'll be donating your organs, and your family has to opt out of donating your organs. And studies comparing the two approaches generally have suggested that a higher organ donation and transplantation rates are seen in countries with opt-out strategies. But this article published in 2019 in Kidney International compared organ donation and transplantation rates in countries with an opt-out system versus an opt-in system. And overall, there was no difference in the transplantation rates. In the opt-in countries, the reduced number of deceased donors was made up for by an increased number of living donors. So it appears that what happens in the opt-out countries is that people assume that you're going to get their organs when you die anyway. So they don't actually become living donors. So overall, opt-out was not the wonderful answer everyone thinks it's going to be. This is another interesting article, and it's a review published by Harriet Etheridge, who used to work at Donald Gordon. And she's a bioethicist, a medical bioethicist. And this was published last year. And she interestingly looked at countries that had changed their policy, and they had gone from an opt-in policy to an opt-out policy. And she says that in no country where this has happened can the increased donations simply be attributed to the switch in policy. There needed to be an accompanying change in addressing public education, awareness, and healthcare structures. So just swapping the policy alone was not enough, and it actually can lead to medical mistrust where the country just suddenly decides to change its policy. She suggests that in developing countries such as ours, it would be better to work towards making functional the systems that we already have in place, rather than to spend a fortune on trying to change our policy. Right, so let's have a look at xenotransplantation. This is not new. This has been attempted for many years, and initially with chimpanzee hearts back in the 1960s. And whilst outcomes were promising, chimpanzees are an endangered species, so they're not a good source for the growing need of organ transplants. And it's been outlawed in most countries. You can't use a chimpanzee heart anymore. And by the mid-1990s, investigators had decided that the pig was the way to go. The pig would be the most appropriate xenograft source animal because you can grow pigs. The anatomy is similar, but there's one big issue with pigs, and that is that humans have a high level of natural antibodies to porcine antigens, and this results in hyperacute rejection. But advances in genome editing make this a realistic option for the future. So watch this space. Okay, the next barrier is that we don't have enough living donors. Okay, again, it's related to lack of knowledge. It could be related to the medical risk to the donor. So pre the 2000s, there's a lot of articles that say kidney donors live longer. In fact, there's one with the title that says kidney donors live longer. But they had compared kidney donors to the general population, as kidney donors are a select group of individuals who are pretty much ultra healthy. You go through a lot of tests before you can give away your kidney. So when they matched the cohorts to people who are also ultra healthy who didn't give away their kidneys, they found that there potentially is a medical risk, particularly to Black African donors. What about medical mistrust? You know, the international organ trafficking scandal did not assist us. And then lots of donors come forward but are not accepted. And I'm going to show you some work from our own transplant unit. It was published in May this year. And we looked at the reasons for non-donation and the outcomes following donation in 1,208 potential donors who came to our renal donation clinic between 1981 and 2015. And of the 1,208 donors that were assessed, less than 1/4 actually went on to donate their kidney. 910 or 75.3% of the donors actually failed the transplant workup. If we look at reasons why, they're shown here. So medical contraindications were the commonest cause for disqualification. We picked up hypertension, obesity, renal insufficiency, HIV infection, or a combination of them as the most prevalent cause for medical disqualification. 209 donors were excluded for psychosocial factors, including 97 donors that voluntarily withdrew. People arrive at the clinic and to donate their organ, but they're not really sure about what it actually involves. And then immunological barriers excluded 19% of these people. And if you look at their about ABO incompatibility, they excluded 10.5% of the patients. We'll talk about that later. Okay, if we look at the outcome of the donor evaluation, the patients who pitched up to donate their kidneys, you know, only the 298 that ended up donating their kidneys, Black donors were more likely to fail to proceed to transplant. So 84.8% of the Black donors failed donor workup from a variety of reasons. You can see from all the reasons, but mainly from medical reasons and from ABO incompatibility. In potential donors who went on to donate, remember I told you previously that the US data shows that it's possible that there's a greater risk to the Black African donor, particularly if you're male, post-transplant to you getting hypertension or proteinuria or kidney disease. In our patients who had a 5-year follow-up, there was no association with ethnicity with long-term outcomes. In fact, if you look at GFR, see my pointer. The CKD epi-GFR was actually better for the Black donors versus the non-Black donors at 5 years. So what are some potential solutions to this, right? So we need to improve community awareness. We need to, particularly around organ transplant and organ donation, we need to encourage healthy living, right? If you never develop end-stage kidney disease and you're not going to need a transplant, we can have organ donor drives. You know, overseas, they link getting a new driver's license and they ask you whether you want to become an organ donor, and you can sign up right then and there. And they've shown in the UK that greatly bolstered numbers. In some countries, people visit your house to find out if you want to give away your organs. And they found that in certain countries that works quite well. And now with social media, you can have social media campaigns and get the word out there. So let's look at some other potential solutions. So transplanting against the ABO blood group barrier. Remember in our cohort, we had 10.5% of patients who were excluded from giving away their kidney from this. This means that in South Africa, if you are an AB, a person who's got an AB blood group, you can only give your kidney to someone who's AB. But if you're O, you can give your kidney to anyone. But if we're going to transplant against the barrier, we might give someone who's a B blood group's kidney to someone who's an O, okay? And this is done internationally. And here it shows, this is a meta-analysis. And the main pros are decreases the waiting times on the list and it increases the overall prognosis. But the big cons, and if you look here as well, the big cons are it requires intensive immune suppression, right? You need to prepare these patients. They need to be plasma exchanged. Their immune systems need to be wiped out, basically, for them to accept these kidneys. And there's a great increased risk, not only of infective complications, but of dying from your infectious cause. And also there's a higher risk of rejection in these transplants. So what about something called a paired kidney donation? This is, let me explain this. So my brother needs a kidney, but I don't match my brother, and your brother needs a kidney. So I can give my kidney to your brother, and you give your kidney to my brother, right? So this can happen in long chains, and overseas this can happen in like 15 to 20 people, where I give my kidney to your brother and you give your kidney to someone else's brother, and it goes all the way down the chain until we close the loop. And the importance of this is it allows for the incompatible recipient to receive a more healthy, compatible kidney, right? So if my brother couldn't receive my kidney, instead of him having to undergo desensitization or an ABO incompatible kidney, my kidney is given to someone who it's more compatible for, and my brother gets a kidney where his kidney, that will be more compatible for him. Okay, so there are multiple benefits for this, right? The transplant candidate, obviously you get a transplant. You don't have to wait on dialysis and accumulate all the morbidity and mortality related to dialysis. The patient gets a living donor transplant, which is better than getting one off the list, which is a cadaver. You then avoid all the desensitization protocols and the risks associated with ABO incompatible kidneys. So what is the outcome data here with these paired exchanges? And overall, it's been encouraging. Due to the living nature of donation, the outcomes are better than patients getting kidneys off the cadaveric lists. Okay, so there's some interesting variations to these paired donations that have been tried worldwide. And the first is called a trans-organ paired exchange. Okay, so my brother needs a kidney, but for some reason, some kidney-specific reason, I can't give him my kidney, but your brother needs a liver. So I can give your brother a piece of my liver, and you can give my brother your kidney. Okay, I mean, there's some obvious risks, there are concerns about this, right? The surgical donation is very different for two organs. The mortality risk for the donation, the kidney donation, is 1 in 3,000, but for liver donation is 1 in 500 surgeries. The next option is something called the Advanced Donation Program. You donate your kidney now, and then you receive a voucher so that your intended recipient can utilize the voucher at a later stage to receive a kidney when they need one. I don't think I need to explain the concerns about this process. So in conclusion, Harriet Etheridge in her article summed it up quite nicely. She says, the success to organ donation policies seems to depend on clear communication, which is reinforced by extensive government buy-in and willingness to respond to public sentiment should the need arise. Widespread investment in human resource infrastructure is needed at hospital level, with people capacitated to have difficult conversations with families and identify potential donors. Technical support with the capacity to maintain donor registries and transplant waiting lists is also essential. Furthermore, these mechanisms need to be accountable through diligent reporting of verified data that are made public. This boosts public trust in the transplant system by demanding accountability and transparency, vital elements for the success of organ donor programs. So most of us are not going to have an influence on government policy, and we're not going to be bioengineering organs in our offices. What we can do is to get the organ donor conversation started and to continue the conversation. Let's speak to our colleagues, let's speak to our patients and their families, let's speak to our communities about the true importance of organ donation. So are you an organ donor?